HBCM lectures on musicians' hand dystonia. Lecture 2, Case Study C1. Etiological factor in guitarist's right hand. Author Joris Lijnse, Director, Hand-Biomech-Ctr-Musicians. Hello, my name is Joris Lijnse. I have established and direct the Hand-Biomech-Ctr-Musicians in Belgium. The HBCM is producing a series of lectures on musicians' task-specific hand dystonia. These lectures consist of a theoretical model, presented in Lecture 1, of how peripheral factors may trigger the condition, and follow-up lectures that present case studies of peripheral factors in musicians' hand dystonia. The here following lecture presents the first case study. The lecture consists of 4 parts. Part 1 covers the introduction, case presentation, and the diagnostical identification of hand factors. Part 2 covers the biomechanics relating the hand factors to the playing dysfunctions. Part 3 presents additional diagnostical biomechanical experiments. Part 4 presents the case discussion and conclusions and its relevance for current neurological musicians' hand dystonia research and treatment. Part 1. Introduction, case presentation, hand factor identification. Introduction. This case study was peer-reviewed, published in 2007 in Movement Disorders. However, this lecture presents additional unpublished scientific materials, while also the lecture itself is under authorship. Therefore, the lecture and its contents have been registered in CERN's Zenodo Scientific Data Repository and should be cited accordingly. Videos and graphic artwork, including graphic model results, were produced by the author and may not be reproduced unless by the author's consent. The reader is assumed to be familiar with the nomenclature, generic scenarios, and supporting anatomical facts of the model on peripheral factors in musicians' hand dystonia, further noted as the PF-MHD model presented in HBCM Lecture 1, published at Zenodo. Why this case? The case is about a subclinical hand effect and demonstrates scenario 5 of the PF-MHD model. Specifically, the case demonstrates the following: extreme task specificity of dystonia symptoms. Therefore, the case satisfied the applicability conditions of the PF-MHD model. The defect causes movement compensations competing with playing motions. The case reveals processes of how these compensations generate dysfunctional behavior in a finger without defects. The movement compensations are biomechanically consistent and therefore unlikely to result from etiological central nervous system predispositions. By the personal observations of the author, most musicians' hand dystonia cases seem to be biomechanically associated with overconstrained hands, meaning scenario 4 of the peripheral factor model. However, the analysis of overconstrained hands is generally complex, among others, because these hands are clinically normal and analyzing the dysfunction involved advanced multi-articular mechanics. In contrast, when a defect is identified, the analysis of its functional consequences is generally more straightforward. Therefore, the case studies in the HBCM lectures will start with the musician's hand dystonia associated with a defect, scenario 5, for being simpler to analyze. Again, the reader should be cautioned that such defects are likely involved only in a minority of musicians' hand dystonia cases. The case will be presented chronologically step by step, as in the analysis in reality took place. Case presentation. A classical guitarist, male, age 44, presents with a 7-year disc control problem in the right hand. The specific complaint is that the right hand index finger does not properly extend when playing its string. Hand function is normal in daily tasks. This video shows the index dysfunction as demonstrated by the musician. Medical history. The complaint was in other centra diagnosed as focal hand dystonia, compulsory index flexion in playing. Treatments in the past 7 years had been ineffective. The hand itself was never systematically examined. Identification of hand factors. Recapitulation of the peripheral factor model. The model has 3 parameter sets. One set consists of the physical properties of the musician, with focus on the musculoskeletal system of the hand and possible clinical factors. This set determines the playing movements the musician can physically make. The second set consists of the properties of the hand-instrument interface. This set determines the required movements, that is, the movements that are needed to play the instrument. The third set consists of all behavioral aspects: the playing technique, level of performance, musical activities, practice intensity and methods, etc. This set determines the occupational load. At all times, the musician faces a fundamental test. Are the required playing motions part of the physically feasible motions, given the challenges of the occupational playing load? If not, then some form of movement compensations must be developed to resolve the conflict between the playing demands and the physical means. In certain factor combinations, these compensations might develop into dysfunctional overcompensations, producing dysfunctional playing movements diagnosed as task-specific hand dystonia. In this model, diagnostics consists of detecting and weighing the interplay of these factors. Procedurally, first, the hand factors and possible clinical factors will be investigated to determine if physical limitations or defects exist causing conflicts in the fundamental test. In the hand evaluation, the index showed no anatomical limitations on finger independence, no apparent joint ligament damage, no limitations of joint ranges or hyperlaxity, and normal strength in all muscles in left-right comparison. Moreover, no significant anatomical independence limitations, joint range impairments, apparent defects, or muscle weakness were present in the other fingers. The results of these evaluations were puzzling. The index and other fingers were independent, fully functional, and seemed free of defects. By these determinations, according to the peripheral factor model, biomechanical and anatomical factors within the index or between index and the other fingers could not have caused the index dysfunction. When the author expressed puzzlement about the index being biomechanically apparently normal, while yet dysfunctional in playing, the musician took the guitar and played a very fast piece of music. To even greater puzzlement, in very fast playing, the index was basically asymptomatic, fully controlled, and displayed a superior playing technique with supple, small, and highly effective string plucking motions. Paradoxically and atypically, the dystonic symptoms in the index occurred only in slow playing. Usually, in musicians' hand dystonia, it is the opposite. Fast motions will be the most symptomatic. To investigate, detailed videos were now recorded of the slow and fast playing shown in this lecture. The playing motions were further analyzed using these video documents. While puzzling, from these observations, some fundamentally important conclusions could yet be drawn. Even after 7 years of symptomatic slow motions, fast playing of index and other fingers remained basically unaffected. This demonstrated that mere central nervous system predispositions combined with repetitive motions could not be causative of the index dysfunction, since fast motions are repeated many times more than slow motions. The extreme task specificity of the symptoms with almost unaffected fast motions suggested that in this case the peripheral factor model would likely be valid. Indeed, a high degree of task specificity is a major applicability condition for the peripheral factor model, as was discussed in Lecture 1. In view of symptomless playing of the index in fast motions, the videos of slow playing were analyzed again. In the video at the next slide, the reader should pay attention to the behavior of the thumb. For further use, some basic anatomy of the thumb will be reviewed. The thumb end joint is called the interphalangeal joint, noted as IPG. The thumb middle joint is the metacarpophalangeal joint, noted as MCP joint. The thumb base joint is the carpo-metacarpal joint, noted as CMC joint. The end joint of the thumb, i.e. the IP joint, is controlled by two large muscles positioned in the forearm. The IP joint is flexed by the flexor pollicis longus, noted as FPL. Its large muscle body arises along the palmar side of the forearm. Its tendon crosses the wrist through the carpal tunnel, runs at the flexion side of the thumb joints, and inserts in the end phalanx. The IP joint is extended by the extensor pollicis longus, noted as EPL. The EPL muscle body arises at the back of the forearm. Its tendon crosses the wrist dorsal to the CMC joint and runs at the extension side of the MCP and IP joints to insert in the end phalanx. With this nomenclature, the functioning of the thumb in the video of slow playing can be described. The video showed dysfunction in the thumb that was even more pronounced than in the index. The thumb dysfunction consisted of severe co-contractions of flexor pollicis longus and extensor pollicis longus, which are the only flexor and extensor of the end joint of the thumb. In the context of musicians' hand dystonia, such co-contractions are also called cramping. The co-contractive FPL-EPL forces in the thumb seemed more severe than in the index. There was a tendency to severely hyperflex the thumb IP joint. However, thumb cramping was readily relaxed when the thumb needed to strike a string. Remarkably, thumb dysfunction was not mentioned by the musician as a complaint. In fact, the musician was not fully aware of the severity of the thumb symptoms, perhaps because he considered any thumb dysfunction associated with or consequential to the index dysfunction. Having observed the severe thumb dysfunction in slow playing, thumb function was studied in fast playing using the following video. The video showed that in thumb fast playing, FPL-EPL co-contractions did not systematically occur in contrast to slow playing. However, hesitations and irregularities in thumb playing did occur. These were not associated with erratic index behavior. The index played fast with perfect control unless the thumb hesitated. Then the index tended to flex towards the thumb tip as in slow playing. This suggested that thumb dysfunction triggered index dysfunction, not inversely. In summary, in fast playing, the index showed normal control. Index discontrol only appeared in slow playing motions. In contrast, the thumb displayed unstable function in both slow and fast playing. Therefore, the analysis now focused on the existence of adverse biomechanical factors in the thumb. At investigation, no problematic factors were apparent in the thumb. There were no anatomical independence limitations. The individual muscle strength of FPL or APL was comparable left-right. There was no apparent joint ligament damage, although the CMC joint was somewhat lax. There were no abnormal limitations on the joint ranges of motion. Flexion of the MCP joint was limited to about 40 degrees of flexion, but this is not abnormal in a thumb MCP joint. However, according to the peripheral factor model, it would be unlikely that the thumb dysfunction would not have a physical trigger. Therefore, the musician was questioned in detail about a hand's medical traumatic history. Eventually, the musician remembered a long-forgotten accident. 9 years earlier, that is, 2 years prior to symptoms, during the cleaning of a wooden floor, A large wooden splinter had penetrated the thumb index web space. These photographs show the injury as demonstrated by the musician. Left shows the hand posture prior to the accident. Right shows the location and direction of the splinter penetration as recollected by the musician. Left. The splinter completely perforated the thumb index web space from palmar to dorsal, lifting the dorsal skin at the level of the thumb carpo-metacarpal joint, like a tent pole, without breaching the skin as demonstrated by the musician. Right. The presumed palmar point of entry from a possible scar identified by a slight local skin color difference. However, small wounds in the hand palm heal well and the mark was barely distinguishable. The musician himself retracted the splinter. The wound healed without apparent functional consequences in playing. 2 years later, problems with index extension in playing started to develop. However, the index problems could not be a direct result of the trauma. Indeed, the splinter entered radial to the index flexor tendons. The index and thumb digital nerves were likely not injured, otherwise clinical symptoms would remain. There was no apparent damage of the first dorsal interosseous, given normal index functioning in fast playing and normal strength and muscle volume left-right. The index lumbrical muscle and nerve were likely also undamaged, otherwise the index could not be so perfectly controllable in fast motions. Could the splinter have damaged the thenar thumb muscles? Did the splinter injure the recurrent thenar nerve? The thumb thenar muscles are innervated by the recurrent thenar motor branch, which splits from the medial nerve at the level of the carpal tunnel. Distal to the flexor retinaculum, the thenar nerve turns radial and divides in branches that innervate the superficial head of the flexor pollicis brevis, the opponens pollicis, and the abductor pollicis brevis. The exit point of the thenar motor branch from the carpal tunnel and its course to the thenar muscles is anatomically variable. These variations have been extensively documented in the hand surgery literature. Question. The opponens pollicis and the abductor pollicis brevis were fully functional in the right hand. However, could the flexor pollicis brevis be dysfunctional? When comparing the thenar volumes left-right, in the right hand, the distal ulnar thenar edge showed a slightly smaller volume. This is the location of the flexor pollicis brevis muscle. In the next slides, the functional anatomy and biomechanics of unloaded testing of the flexor pollicis brevis will be reviewed. The following definitions and nomenclature will be further used. The thumb joints will be numbered CMC joint 1 through IP joint 3. The MCP and IP joints can only flex and extend. Motions in other directions are excluded by their joint ligaments called collateral ligaments. Hyperextension of the MCP and IP joints is prevented by a parallel ligament called the volar plate. The plane in which the MCP and IP joints move will be called the phalangeal plane, P-plane or PP. The CMC joint is grossly a settled joint with two main directions of motion. The classic nomenclature of these motion directions, abduction, adduction, flexion, extension, is not fully consistent with the functional names of the muscles. Therefore, the following definitions will be further used. PP rotation. CMC joint rotation that moves the thumb metacarpal within the P-plane, as shown in figure A. OP rotation. CMC joint rotation in the O-plane, orthogonal perpendicular to the P-plane. This CMC joint rotation flexes and extends the thumb metacarpal orthogonally to the phalangeal plane, as shown in figure B. The muscles of the thumb can be grouped according to the joint motion planes they control. Motion control in the P-plane. In the phalangeal joint, extension by the extensor pollicis longus, flexion by the flexor pollicis longus. MCP joint, extension by the extensor pollicis longus, extensor pollicis brevis, flexion by the flexor pollicis longus and flexor pollicis brevis. CMC joint, extension by the abductor pollicis longus and extensor pollicis brevis, flexion, flexor pollicis longus, adductor pollicis, flexor pollicis brevis, opponens pollicis. In the P-plane, the CMC EPL moment arm strongly varies with the CMC joint angle. At full CMC joint extension, the EPL moment arm may be of extension. At full CMC joint flexion, the EPL moment arm may be of flexion. Motion control in the O-plane. CMC joint dorsal extension by the EPL. Palmar flexion mainly by the abductor pollicis brevis, assisted by the APL. The flexor pollicis brevis test. Description. With the unloaded thumb in neutral position, flex and extend the MCP joints while keeping the IP joint in hyperextension. Biomechanics. Unloaded testing of the flexor pollicis brevis requires flexing the MCP joint while the flexor pollicis longus remains inactive. Then only the flexor pollicis brevis can fully flex the MCP joint. In the actively moving unloaded thumb, the extensor pollicis longus cannot be inactive, as extensor pollicis longus force is needed to maintain the CMC joint position in the O-plane. Therefore, when the flexor pollicis longus is inactive, the extensor pollicis longus force will hyperextend the IP joint until its folder plate prevents further hyperextension. Therefore, full IP joint hyperextension during MCP joint flexion extension motions is an indicator that the flexor pollicis longus is kept inactive, or at least with so little activity that it does not flex the IP joint. With so little FPL activity, the MCP joint would have to be flexed by the flexor pollicis brevis. This video shows the flexor pollicis brevis test, first in the left and thereafter in the right hand. Results of the flexor pollicis brevis tests. In the left thumb, the MCP joint easily flexed while the IP joint remained extended, meaning that the flexor pollicis longus was inactive or had little activity throughout the test. In contrast, in the right thumb, the MCP joint could not be actively flexed without the IP joint being flexed, meaning that the flexor pollicis longus was activated in the attempt to flex the MCP joint. Conclusion. The right hand flexor pollicis brevis test revealed a problem with flexing the MCP joint with inactive flexor pollicis longus, suggesting that the flexor pollicis brevis was functionally deficient. Etiologically, it is possible, perhaps even plausible, that the right hand flexor pollicis brevis deficiency was caused by the splinter penetration trauma damaging the flexor pollicis brevis and/or its innervation. However, one basic question arises. How is it possible that in the following 9 years, the flexor pollicis brevis functional deficit remained obscure, it is undetected in daily life and in playing? This question can be answered by the following question. How can the MCP joint be flexed in the unloaded thumb when the flexor pollicis brevis is deficient? One possibility is co-contracting the FPL and EPL. When biomechanical conditions on the flexor pollicis longus and extensor pollicis longus moment arms at the MCP and IP joints are satisfied, then FPL-EPL co-contractions produce a residual MCP joint flexion force or moment. This MCP joint flexion force can be balanced by the extensor pollicis brevis, so that the MCP joint is then controlled. The other possibility is bringing the IP joint in the end position of flexion. With the IP joint in the flexion end position, the flexor pollicis longus functions as a dedicated MCP joint flexor. The biomechanics will be explained in the next slides. Thumb MCP joint flexion moment by co-contracting flexor pollicis longus and extensor pollicis longus. Co-contraction of FPL and EPL, while they keep the IPG in equilibrium, produces a flexion moment at the MCP joint when mechanical conditions on the relative size of the moment arms of FPL and EPL at the MCP and IP joints are satisfied. The EPB can balance this MCP joint flexion moment so that the thumb joint is then controlled. However, by the co-contraction of FPL and EPL, the muscle forces will be much greater than in normal control. The analysis of the underlying mechanics is mathematical and for biomechanical specialists. A summary is provided in the appendix at the end of this part 1 of this lecture. MCP joint flexion by the flexor pollicis longus with the IP joint in its flexion end position and inactive flexor pollicis brevis. When the IP joint is flexed by the flexor pollicis longus into its flexion end position, the FPL force is balanced at the IP joint by the collateral ligaments and the bone contacts. In this end position, the IP joint is rigid as if the joint is fused. The FPL will then function as a dedicated flexor of the MCP joint. The MCP joint is then fully controlled by the FPL as flexor and the EPL and EPB as extensors. Biomechanical condition. To control the MCP joint in this way, the EPL force needs to remain smaller than the extensor force needed to unlock the IP joint against the FPL force. When this condition is satisfied, the IP joint will remain locked by the FPL force and the MCP joint will be fully controllable during motion without flexor pollicis brevis forces. This video shows the right hand MCP joint flexion by the flexor pollicis longus after the IP joint is put in its end position of flexion. The MCP joint can then be normally and forcefully flexed. At the end of the video, the maximum passive flexion range of motion of the right hand MCP joint is shown.
And then back. Yes. And then back. Yes. And then back. Yes. Once more. Okay. Yes. Okay.
In conclusion, why was the flexor pollicis brevis deficit not noticed? Hypothetically, thumb flexion with the IP joint flexing before the MCP joint may seem like normal thumb flexion. Also, in loaded thumb situations, similar functional compensations may mask a flexor pollicis brevis deficit. There might also be some remaining function in the flexor pollicis brevis, although not enough to flex the MCP joint autonomously. Conclusion of hand factor investigation. The test revealed a right hand that was anatomically very suitable for playing, as testified by a superior fast playing technique. However, there seemed to be a clinical factor, a functional deficit in the flexor pollicis brevis. In part 2, it will be investigated what movement compensations and overcompensations in playing were likely associated with this defect. End of part 1. Identification of peripheral factors.